So please, we'll maintain the decorum.
Welcome, Ramesh Kumar sir. Welcome.
Good evening, sir. President, sir, Dr. Hemant, Dr. Bandarkar.
Ramesh Kumar sir.
Good evening, sir. Bakul sir, Ramesh sir, good evening.
Good evening.
Hello, Bakul sir.
Good evening.
Bakul sir, Bakul bhai. Hi.
Hi.
This
Good
is
evening, sir.
I'm not getting the full screen. Hi, Dr. Swati, speaker. Ramesh, this side.
Evening.
Yeah, light નથી આવતું સાલી.
Good evening, Bakul sir.
Good evening, Amol. How are you?
Fine, sir. Fine.
Yes.
Hi, Samir.
Hello, sir. Good
Hi.
evening.
Good
Nice
evening.
to see you all here.
Yeah, thank you so much. Great opportunity to be there with you all.
Nine o'clock.
Good evening, everyone. On behalf of Maharashtra Academy of Pediatrics, a very warm welcome to all the respected dignitaries, seniors, colleagues, and all the attendees who have joined through the live YouTube channel. Before I start, I request everyone to please keep their mic on mute, and if any queries, can put it in the chat box. We will attend at the end of the session. Friends, as in the evaluation of any other system, history taking is a basic step in cardiac evaluation also. Either the maternal history during pregnancy or postnatal history or the family history. All are important. We all have felt the thrill of detecting a murmur, bounding of our pulses with the gallop rhythm. Let us learn back to basics. So today, Maha EP has arranged a subspecialty academic session on pediatric cardiology. Now I request our Maha EP President, Dr. Hemant Gangulia, sir, for the opening remark. Welcome, sir, and over to you.
Thank you. Namaste, respected chief guest, our beloved IAP President, Dr. Ramesh Kumar, sir, faculty, dignitaries, friends, and all the attendees on this Zoom, as well as on Maha IAP YouTube channel. As well, I acknowledge the presence of our visionary president, past president, Dr. Bakul Parikh, sir. This is the first episode of Maha Subspecialty Connect of 9-episode series to be held on every second Friday of every month. I must appreciate the efforts of Dr. Samir as well as Dr. Jay, and I'm sure all upcoming episodes regarding the subspecialty intricacies will be the great learning ones which will help us in our day-to-day practice. All the best wishes, and let us have the great learning about pediatric cardiology. Thank you very much.
Thank you, Gangulia, sir. Yes, today we are fortunate to have with us Dr. Ramesh Kumar, sir, as well as Bakul Parikh, sir. I request our Maha EP Secretary General, Dr. Amol Pawar, sir, to please welcome our guests. Over to you, Amol, sir.
Good evening, friends. Now I invite today's chief guest, Dr. Ramesh Kumar sir, our beloved CIP president, for his blessings on the first episode of our innovative idea of Maha IAP Subspeciality Connect. Over to you, Ramesh Kumar sir. Welcome, sir.
Thank you, my dear Dr. Amol, as well as Dr. Neha, President of Maha IAP, Dr. Hemant Gangolia, our mentor and guide, as well as the visionary president of 2020, Central IAP President, our dear friend, Dr. Bakul Parekh, Secretary of Maha IAP, Dr. Amol Pava, scientific coordinators of the program here today, Dr. Samir Sadavarte and Dr. Jay Bhandarkar, faculty, Dr. Swati Garekar and Dr. Ronak Seth. My dear friends, I can see a lot of my dear friends from Maha IAP as well as across the country who are joined for this great session. And dear friends, a good evening and a great privilege to be there on this Friday evening for your Maha IAP Subspecialty Connect. For me, Maha IAP is my second home. I did my NT in Maharashtra only, and I owe my pediatrics to Dr. VM Medical College, Sholapur, way back in 1993. And Dr. Atul Kulkarni and Dr. Sanjay Gorpade were my registrars, in fact. And I'm so fortunate that the great Maha IAP, I could be a part of, indirectly a part of Maha IAP at all times. And at Indian Academy of Pediatrics, we owe to Maha IAP being the largest branch with more than 4,000 members, contributing very actively to all the academics and all the organizational activities of the Central IAP. And with the virtual platform around, it's so glad to see that Maha IAP has taken off in a great way the year before and continuing the legacy in 2022 with the great academics. And late yesterday night only, I learned from Samir, my great friends. We were talking at around 12:30 in the night about the activities of Maha IAP, your subspecialty activity on Friday, another activity, or even the extracurricular activities on one Friday. So we are set apart every Friday for one or other activities. And that speaks big about the organization where you keep the activities, the members ticking. That is very important. They cannot be at any moment, they should not lose the momentum on some or other platform. And I am sure that our Amul baby, I said Amol Power is an Amul baby for us. He looks like an Amul baby only, and always I'm so happy to see his charming and smiling face. And of course, Dr. Ronak is also, we are all having that Sachin Tendulkar faces, something like, so good to see you all charming faces, and so happy that you are all taking it forward. And Dr. Samir and well, of course, you have got your stalwarts. Dr. Ubendra is there as a president-elect, Dr. Bakul Parekh and Dr. Vijay Avale, as well as Dr. Nitin Shah, Dr. Rohit Agarwal, and as well as Dr. Lokesh Sharan, of course, Dr. Amdekar sir. All doyens are there to lead you and guide you locally itself. And being a virtual platform, it can be across the country. So congratulations to Dr. Hemant Gangolia sir, as well as Dr. Amol and Dr. Jay Bhandarkar and all the seniors of Maha IAP for taking this in a big way. And I'm sure that I can catch up with you at the earliest for next your great conference. Last 2 months back, I lost the opportunity because of COVID, way back in a Raigarh meeting. So I'm looking forward to catch up with you at the most moment. And my best wishes for the activities of the Maha IAP and this great session here today. And great time of academics with the Maha IAP, the stalwarts taking it forward in a big way. Thank you very much, and thanks for the opportunity. And I always consider that's a great privilege. Thank you.
Thanks, sir. It's all Friday releases. On all Fridays, we are having all releases.
Just like a movie release.
Yes. I would like to ask Dr. Bakul Parekh sir also to speak 1 or 2 sentence blessings. He is our guide, philosopher, everything for us. Yes, sir.
Yeah, thank you, Dr. Hemant, for your kind words. I recognize the presence of our National President, Dr. Ramesh Kumar, my dear friend and Secretary of Maha IAP Amol, and of course, Samir, nobody can forget him. Nobody can say that I have not seen him. So, Samir Sadavate, Dr. Jay Bhandarkar, Neha, and of course, our Ronak Seth and the dear speaker, Dr. Swati Garekar, who is a great speaker. I've heard her 2-3 times in past, and I'm sure people will learn a lot from her talk, and it'll be a good deliberation all throughout. So I congratulate especially President Dr. Hemant Gangulia and Secretary Amol Pawar for taking up MyAP activity at a really Maha level, because every Friday you are releasing new movie, and first day, first show is the always theme of our MyAP, and Subspecialty Connect is one of the innovative ideas of these two stalwarts along with MyAP team. And I am happy that you are using virtual platform by which you can reach the unreached, and there are no boundaries. You can call any speakers. Like Ramesh Kumar could not have traveled from Cochin here, but definitely he is present on the platform, and that has made possible because of this virtual platform. So thank you very much and all the best. MyAP is always very, very dear to my heart, and anytime, anything, I am always there. Thank you.
Thank you, sir. Thank you, sir, for that.
Thank you, Dr. Ramesh Kumar sir and Dr. Bakul Parekh sir, for joining and giving us your valuable time and blessings. Thank you so much, sir. For today's session of Maha Subspecialty Connect, Pediatric Cardiology, we have with us two excellent experts who will be delivering their talk on two different topics. And we also have with us Dr. Sameer Sadavarte sir and Dr. Jay Bhandarkar sir for conducting the session. Dr. Sameer Sadavarte sir, he is EB member, Maha IP 2022. He is consultant pediatrician and head of pediatric ICU, Fortis Hospital, Mulund. Dr. Jay Bhandarkar sir is Maha IP State Convener 2022, pediatrician and neonatologist at New Panvel. Sir, welcome, and over to both of you, sir.
Hello, Dr. Jay, Dr. Hemant sir.
Yes.
Yeah. So our
Yes.
dream coming true today that we have decided long back that we should have something related to the subspecialty. And in a total of 1 year, we are doing the 12 subspecialties they are calling. And first time we decided to do it with a heart. So why heart? Jay sir will tell us, because Valentine's Day is coming nearby on 14th of February. And then both of us thought, okay, let's go with the heart first. जब दिल दिया है, हार्ट को दिया है, तो सब चीज बराबर आ जाएंगे. So we have with us a very eminent speaker today with Dr. Unak Seth, who is going to talk about the general exam. Most of our today's audience contains the general pediatricians and also the exam going students and some practicing pediatricians. So let's revise ourselves to start with the most basic thing. And as the time advances, Swati Garekar madam will discuss about the general pediatrics as well as regarding the special cases and advance if the time permits with us. So all up to you, Dr. Unak Seth. So I welcome Dr. Unak Seth. He is the consultant pediatrician cardiologist with a DNB FNB in the pediatric cardiology, and right now working in the Fortis Hospital, Mulund. So Dr. Unak Seth.
Thank you so much, Dr. Sameer sir, and so many esteemed senior pediatricians are here with us, and it is a pleasure to be here and be able to speak to you on this platform today. Are my slides being seen or?
Yes.
Yes, you are audible and visible also, and slides are seen.
Yes.
Okay.
Play. Play the click.
Okay.
Yes.
So good evening, everyone, and thank you for this opportunity with Maha IAP Subspecialty Connect. And it is a pleasure to start off this series of subspecialty lectures with cardiology, considering that this ongoing week from 7th to 14th is also a congenital heart disease awareness week. And I'll be taking you through approach to a pediatric cardiac patient and focusing on basic pediatric cardiac clinical examination. So we will go through what is the tripod of pediatric cardiology, on which the understanding of various disease subsets in pediatric cardiology rests. Then we'll go through, touch upon the various pathophysiologies. Then we'll go to cardiac clinical examination, and then we'll go to chest X-ray and ECG, and then finally we'll come to some clinical scenarios. So pediatric cardiology, the pediatric cardiac diagnosis, almost 80 to 90% in the yesteryears used to rest on a good history and a physical exam, including a reliable 4-limb pulse oximetry. And that clubbed with a chest X-ray and the ECG would give at least a pathophysiological diagnosis in majority of these things are covered well. So the first question that comes to our mind is, does the child have a heart disease? When we come across a child who presents with some features which point towards a heart disease, NADA's criteria are the age-old criteria which we follow and which still hold true because of their solid base. Major criteria is a systolic murmur more than grade 3. Any diastolic murmur amounts to a major criteria, and presence of cyanosis and congestive heart failure definitely. Minor criteria include systolic murmur of a grade 2 or less, abnormal second heart sound, abnormal ECG, and abnormal chest X-ray, abnormal blood pressure. So 2 or more minor criteria can point to a heart disease. Single major criteria is enough to point to a heart disease. Then coming to the understanding of the various pediatric cardiac pathophysiologies, the most common one that we come across is a shunt physiology, whether there is an atrial septal defect or a ventricular septal defect or a ductus arteriosus. There is a left to right shunt across the cardiac chambers, and that gives rise to a shunt physiology. The next one, common one, is a tetralogy of Phallophysiology or a TOF physiology, in which there is a large interventricular communication and pulmonary outflow obstruction. The third is a admixture physiology, where there is complete mixing of blood between in any single cardiac chamber. So, for example, a total anomalous pulmonary venous return amounts to a admixture physiology, because all the pulmonary venous and systemic venous blood will get completely mixed in the right atrium. Then coming to transposition physiology. Transposition physiology is when the systemic and pulmonary connections are in parallel circuit, so that there is only intermixing across the interatrial or interventricular shunts will give mixing between the pulmonary and systemic circulations, and there will be extreme cyanosis. Further, obstructive physiology is also one of the common ones, where there is an obstruction, congenital or acquired, to one of the valves, say aortic stenosis or say severe coarctation of aorta. Then another thing which we need to understand is, and we need to classify disorders into whether they are increased pulmonary blood flow situations or decreased pulmonary blood flow situations. So if we examine a patient completely from the cardiac point of view, and go to a complete analysis of the chest X-ray and ECG, we should try to fit him into one of these physiologies, so that it will help us in the further plan. So what are the salient points in the history of pediatric cardiac patient? Gestational history, definitely important. Maternal infections or exposure to drugs and alcohol. Maternal conditions like diabetes mellitus in pregnancy can give rise to a lot of diseases like asymmetric septal hypertrophy, and even congenital heart defects are more common in infants of diabetic mother. Congenital SLE in the mother can give rise to congenital complete heart block. Then one of the most important factors to assess is the birth weight, the weight gain, and the feeding pattern of the baby. How much is the respiratory distress, whether there is tachypnea during feeding cycles, is there presence of cyanosis, spells or squatting episodes. Facial edema and dependent edema points to congestive heart failure, and effort intolerance is also a sign of low cardiac output. Other cardiac symptoms which we should also touch upon are chest pain, syncope, palpitations. Joint symptoms are important for rheumatic symptoms, rheumatic heart disease. Neurological symptoms are also sometimes associated with congenital cardiac defects. Family history and history of medications is important. Going to the cardiac clinical examination, the general examination, initial features which we should assess are the general appearance of the baby, how is the build of the child, the nourish, whether there are any dysmorphic features, is there pallor and edema. Cyanotic children will have we should look for central cyanosis and clubbing. Charting of growth parameters is one of the most important things to guide even the timing of intervention in congenital heart diseases. Going further, The vitals are important with heart rate and a detailed analysis of the pulse, respiratory rate, and the work of breathing. Getting a reliable blood pressure reading in a child is very challenging most of the times, but it cannot be neglected, and it is a essential part of the cardiac exam. Pulse oximetry, we should try to upper limbs and any lower limb saturation. And as much as the arterial pulse is important, the venous pulse is also important. So we should always look at the jugular venous pulse. There are some congenital syndromes which are associated with cardiovascular abnormalities. Common ones are DiGeorge syndrome is very commonly what we come across. It is due to 22q microdeletion, 22q11 microdeletion, and it presents with a variety of conotruncal defects. Down syndrome, obviously, we all are aware of the around 50% incidence of congenital heart disease in Down syndrome. Marfan syndrome can present with abnormalities of the aortic or mitral valves. Noonan syndrome presents with pulmonary stenosis. Congenital rubella syndrome can present with patent ductus arteriosus and pulmonary hypertension. There are trisomies 13 and 18, which also have very common association with congenital heart diseases. Then coming to some other associated organ system malformations which have a coexisting involvement. So very commonly what we see is either a horseshoe kidney or a unilateral agenesis of the kidney. Then GI abnormalities like an imperforate anus and tracheoesophageal fistulas, which have commonly a congenital heart defect involved. These are so we come across many types of dysmorphisms in our clinical practice. Syndrome are very obvious and can be easily picked up. Some of them are very subtle and need a to come to a specific diagnosis. This child would had a very subtle slanting upslant of the palpebral fissures, central obesity, and polydactyly in all four limbs. So this was a Bardet-Biedl syndrome, and the child had a common atrium with a cleft in the anterior mitral leaflet. So now I see that there are many participants in the audience. I would like to have some interaction from the audience, and I've played a short video clip. Are there? Can I make the thing interactive and have some interaction from the participants also?
Yeah.
Madam Pallavi, you can allow everybody to, they can.
Permission is given. Permission is given.
Yes, yes. So anybody to interact can just unmute themselves and can contribute.
So any of
So it's written somebody by Edwards syndrome.
Yes, so that is a good diagnosis. There is very obvious overlapping of all the fingers, and there is marked failure to thrive in this child with multiple other dysmorphic features, and this child was severely failing to thrive and diagnosed as a trisomy 18. So coming to the pulse evaluation, we need to know the rate, rhythm, and volume of the pulse. Force and tension of the pulse are not very commonly used in pediatrics, and it is really difficult to assess those things. But the contour or character of the pulse is essential to note in pediatrics as well. And so we all know some of these pulses which we commonly come across are a water hammer pulse that we see in severe aortic regurgitation, a pulsus tardus or a low volume, low rising pulse that we see in aortic stenosis. Then pulsus bigeminus is where there is one normal sized wave and one smaller beat alternating. So that is due to multiple ventricular ectopics or a ventricular bigeminy. The pulse in atrial fibrillation regularly irregular pulse. So the character of the pulse is very important. Another very important point in pediatric pulse examination is looking at all the peripheral pulses. So right from the carotid to both the brachials, radials, and lower limb pulses, including femorals, dorsalis pedis, all the pulses should be evaluated in detail. Then coming to the venous pulse, the JVP. JVP is frequently neglected in a pediatric cardiac exam because many times the children are not very cooperative for this exam. But in a child bigger than say 3 to 4 years, we should look for it carefully. And even in a smaller child, some degree of evaluation of the JVP is possible to come to know some basic features of the JVP. Like this exaggerated V wave can be seen in tricuspid regurgitation. If there is complete heart block, then we see these tall, huge cannon waves, A waves, tall, huge cannon A waves. So coming to a very important part of pediatric cardiac exam is saturation or pulse oximetry and evaluation of the cyanosis in a child. So now there are two babies here. Will anybody in the audience want to tell which baby are they suspecting to be cyanotic, or both are looking okay?
So right side baby cyanotic, central cyanosis.
Okay, yes. So Bhandarkar sir has clinched the diagnosis.
And left side maybe have peripheral cyanosis, maybe, I don't know.
Okay.
Both are well bundled, that's what I can say. If they are
completely
open,
that is how they come to us.
Yeah.
Okay, so any Bhandarkar sir, any take on how much the saturation would be for this cynos baby?
I think saturation should be below 85% for the to see the cyanosis. That is central cyanosis to be in the mucous membrane, mainly.
Correct.
When I talk, then I expect you to explain between peripheral cyanosis and central cyanosis. This is more for the practitioner, right?
Correct. So in cardiac causes of cyanosis, where there is mixing of blood and circulation of desaturated blood inside in the body, we see central cyanosis. Central cyanosis is best evaluated in the oral cavity to look at the tongue and the mucous membranes of the oral cavity. Also, we should look at the nail bed of the child. So, but more reliable if we can have a look at the tongue and mucous membrane, that is really more reliable to detect central cyanosis. Peripheral cyanosis is very common in sorts of sick children who come with a relatively unstable circulation. Any sort of a sick child can have a collapsed peripheral circulation in severely vasoconstricted state and have peripheral cyanosis. Or there can be cold exposure hypothermia that can also cause severe vasoconstriction. And so we see peripheral cyanosis only on the fingertips or on the on the lips. But so that is peripheral cyanosis. So the baby on the right had a saturation of around 55%. So here we can make out that the baby is cyanotic, but even to the trained eye to make out that the saturation is so low, it is only 55%, is very difficult. So there is no alternative to a reliable pulse oximeter exam even in the smallest of the babies. And as correctly said by Bhandarkar sir, the left-sided baby had a normal saturation, and there is only some degree of peripheral cyanosis. So how to take a good pulse oximetry exam in the baby? Most of our clinics and hospitals will have this usual pulse oximeter with the usual adult probe that can be worked with in say a baby who is more than 3 to 4 kilos sometimes, but and that sometimes can be unreliable. The best probe that comes is a wraparound probe, which can be used even in the smallest of units, and it gives very reliable pulse oximetry. evaluation. Another thing that is important is to look at the waveform of the pulse oximeter. So we should have a reliable pulsatile tracing on the monitor, and that value can be taken as reliable. The right-sided value has a good tracing, and hence that is reliable. As compared to the left one, it is just having a lot of artifacts, and which should not be taken as a reliable pulse oximeter. Then coming to blood pressure measurement, it is very essential, and it is now recommended worldwide that all more than 3 years of age, all patients coming to a outpatient for an outpatient evaluation should have a blood pressure taken. It is sometimes difficult in the small children and to get a reliable reading, especially when the child is uncooperative. But most of the time, a good reading can be taken when the child is sleeping or feeding. So, and it is better to chart these values of blood pressure on these charts and look at the percentile of the systolic as well as diastolic blood pressure of these patients. Nowadays, we have apps and websites which can give easily the percentiles or whether they are outside the normal range of blood pressure for that age and height.
Whether it applies same to Indian context, same app? Percentiles.
Yeah, so this obviously this AAP guidelines have data which was taken with American children, but in context of our Indian children, because the parameters that they take are height and age, because height is also included, so that will automatically sort of correct for our Indian population also to some extent, not completely, but it gives a reliable base for deciding how frequently we should monitor or how we should intervene for that child if there is hypertension.
Okay.
Again, another important aspect is taking the weight and height accurately and charting it accurately on these charts. Now here there are a variety of charts that we use. The WHO and IAP charts are on the left, and what happens sometimes is in the smallest of babies, there is, when we want to track the growth of the baby month by month or week by week, it becomes little bit difficult on these charts where there are multiple parameters and it becomes a little bit crowded. So a better way is to go to this chart, which is by the CDC again. So it is American, and so we may not follow all these centiles to the dot for interpretation, but as far as growth charting is concerned, the most important aspect is looking at the curve and looking at flattening of the curve or following of the curve. So that is very nicely done here on these charts, where these charts are for birth to 36 months. So these are very essential and good tool for small babies, where we are wanting to track them once in a fortnight or once every month. Then coming to precordial examination, we are all aware about precordial examination, so I will not go into those minute details, but just to give an overview, we have to look at the chest wall, the precordial shape, whether there is any sternal deformity like a pectus excavatum or carinatum, the apex impulse, the location of the apex impulse, and whether there are any additional pulsations. So in pediatrics, auscultation and palpation, they go hand in hand, and percussion is rarely used in small children. Accurate apex determination is essential for a meaningful auscultation, because otherwise auscultation can lead you wayward if the apex determination is not accurate. However, complete palpation may make the kid uncooperative, so it is essential to focus on maximizing the diagnostic info in the initial exam as much as possible. So one of the most important aspects for a young trainee pediatrician or pediatric residents is to differentiate systole from diastole. It is very difficult in child to differentiate systole from diastole and to say whether murmur is or a particular sound is heard in systole or diastole. So always we should always palpate the carotid apex and auscultate simultaneously. The S1 coincides with the apex beat. And another clue that we should use is the sound that is heard best at the base of the heart is the S2. So these are the classical areas of auscultation which we commonly which we have to focus on to which can give a clue to underlying diagnosis, and the underlying murmurs can be best heard in those areas. In pediatric cardiac exam, low frequency sounds are also more important. So it is important to use the bell of the stethoscope as well. Something like a S3 gallop can be best heard with the bell of the stethoscope. We all know about these areas of the heart and areas of auscultation, so I will not go into that. So heart sounds, S1 is definitely well heard by all of us. S2, the splitting of the S2 is extremely difficult to appreciate in a crowded outpatient clinic. But going to the details of that, so the second heart sound is formed of an aortic sound and a pulmonary sound. In inspiration, the pulmonary sound gets delayed, and so we hear the splitting of the second heart sound. Then coming to the S3 and S4. So the S3 is the early diastolic filling sound, and the S4 is a sound of atrial filling during diastole. So these are the S3 and S4 are the two sounds that are heard in diastole. Then coming to follows the first heart sound is the ejection click, that is commonly seen in valvar aortic stenosis or valvar pulmonary stenosis, where the pulmonary or aortic systole, but because the valve is congenitally stenotic to its full extent and makes a click. So that we hear in early systole after the S1. And another sound that we have to focus on is the opening snap that we see in diastole, that is seen in commonly in mitral stenosis, where the stenotic mitral valve opens in diastole and it produces a opening snap. So there are some S2 abnormalities which are very important. However, it is very difficult to appreciate all of these abnormalities in a routine outpatient practice. However, some of the common ones that we should know are that a P2 gets accentuated in pulmonary hypertension. Similarly, the P2 is absent in pulmonary stenosis or pulmonary atresia. Again, if there is a right bundle branch block or any type of a right volume overload, second heart, that will delay the P2 and it will produce a wide split of the second heart sound. So here are some important things that we should keep in mind. A wide splitting of the second heart sound is very commonly what we see is atrial septal defect, where we see a wide fixed second heart sound and a ejection systolic murmur in the pulmonary area. A narrow split second heart sound is commonly seen in a child with pulmonary hypertension due to some cause. If the pulmonary hypertension has progressed further, then the S2 will be single. So this is just to give an understanding of all the murmurs that we commonly appreciate in pediatric cardiac exam. The ejection systolic murmurs are a crescendo decrescendo murmur, and they have a diamond shape and they peak in systole. The more the severity of the stenosis, the further the peak will be towards the second heart sound. Holosystolic murmurs or regurgitant systolic murmurs are present throughout systole. So they will mask the second heart sound and completely mask the second heart sound. The second heart sound we will not be able to appreciate it separate from the murmur. And diastolic murmurs, they most commonly what we see is a mitral stenotic murmur, which starts in mid-diastole after the opening snap. Another common murmur that we see is a patent ductus arteriosus, which gives rise to a continuous murmur, which the murmur is present throughout the cardiac cycle, and the peak of the murmur is coinciding with the second heart sound. This is just to understand why a holosystolic murmur or a VSD murmur is present throughout the cardiac cycle, because the differential between the left atrial and the left ventricular pressure lasts throughout the systole, and it lasts till the second heart sound. So we do not hear the second heart sound separate from it. Whereas an ejection systolic murmur, the pressure differential between the left ventricle and the aorta is present only till the closing of the aortic valve. So we hear the second heart sound separate. Then there are some murmurs which we commonly come across in pediatric patients, which are completely innocent, means they are not related to any organic defect of the heart. So what we most commonly see is a pulmonary flow murmur in a newborn. Also, what we sometimes come across a pulmonary ejection murmur. These innocent murmurs get accentuated during a febrile illness or during if there is underlying anemia. However, before labeling a murmur as functional, we should ensure that the rest of the cardiac exam is normal, and a good complete examination is important before labeling the murmur as functional. However, over-reliance on murmurs sometimes can be tricky. Murmur identification itself is a challenge most of the times. Most of the other cardiac findings are better identified. The apex beat, the hyperdynamicity of precordium, parasternal heave, thrill of a murmur, JVP and its waves. So all these things are important and have to be taken into consideration together while coming to the conclusion, and over-reliance on just a murmur should be avoided. Multiple clinical observations and findings have to be fit into physiological basis and their hemodynamic correlates, and then interpreted accordingly to give a conclusive diagnosis. So this is one of the common scenarios that we come across. A pediatric resident has evaluated a 12-hour-old baby and has noted a harsh precordial murmur, and he has sent the child for a 2D echo to rule out VSD. What are the comments from the audience on this scenario?
It may be a closing VSD or closing. I can say what is it called? This foramina oval that can give the murmur. So it may not be
okay. Any other takes on this child? This baby is only 12 hours old.
PDA.
You will be closing PDA.
Harsh precordial murmur. Okay.
In closing PDA can give us to murmur, harsh murmur.
Okay. Any other interpretation?
12-hour baby, there should be a pressure gradient across both. So in 12-hour baby, there will be not pressure gradient. So murmur will be not severe in the case of VDSD. It is only when you see the PDA, then only you can have such a murmur.
So correct. So this is one of the common scenarios which we come across, and what is important is to understand that a murmur, what you said is absolutely bang on. It is the presence of a harsh precordial murmur requires a significant pressure difference between the two chambers. However, in a 12-hour-old baby, there is not much difference between the systemic circulation and the pulmonary circulation pressures. The right and left ventricle are more or less at the same pressures. The pulmonary vascular resistance is yet to fall. So having a harsh precordial murmur in a neonate, a small neonate, will essentially tell you or rule out a shunt lesion, and will most likely point to a regurgitant or an obstructive lesion. So either it can be something like a mitral regurgitation or a tricuspid regurgitation, or it could be a obstructive lesion like a aortic stenosis or a pulmonary stenosis. Only these will produce a harsh precordial murmur so early in life before the pulmonary vascular resistance has fallen. So there are some pitfalls of relying too much on murmurs. A hypoplastic left heart syndrome, an obstructed TAPVC, a hemodynamically significant PDA, a TOF with a cyanotic spell. All of these are extremely critical congenital defects which need immediate attention, and almost none of these will have a murmur. Most commonly what we come across is a gallop rhythm. So such soft clinical markers are extremely important to be kept in mind. Okay, so that was clinical examination. Now coming to chest x-rays. So we know about the normal cardiac silhouette on a posterior anterior chest radiograph. The right heart border is formed by the right atrium and the right superior vena cava. The left heart border is formed by the left atrial appendage and the left ventricle inferiorly, and superiorly by the aortic knuckle and the pulmonary artery segment. So on the basis of a chest X-ray evaluation, we can have a basic approach to the differential diagnosis of the heart defect. In a child who is acyanotic, the heart size being increased, meaning there is significant cardiomegaly, and the pulmonary vascularity is also increased, it points to a shunt lesion like a septal defect or a PDA. If there is a pulmonary venous hypertension, it points to something like a severe aortic stenosis or a severe coarctation. If the heart size is also normal and the vascularity is also normal, then it points to a smaller shunt like a small VSD or a small PDA, or it points to a obstructive lesion like an aortic stenosis or a pulmonary stenosis. Similarly, in a cyanotic child, if there is cardiomegaly and decreased pulmonary vascular marking, what we should think about is a Epstein's anomaly or a severe pulmonary stenosis with tricuspid regurgitation. So similarly, there is a we can get a basic idea of the pathophysiology in all these clinical scenarios. The first step is to identify whether the patient is cyanotic or acyanotic. The second step is to find out whether there is cardiomegaly or no cardiomegaly. And the third step is to find out the pulmonary vascularity. One of the common findings that we see is the child is very cyanotic, there is no cardiomegaly, and the pulmonary vascular markings, there is pulmonary significant hypertension that is commonly seen in an obstructed TAPVC. So now coming to some interaction with the audience. This is a chest X-ray. Anybody would like to comment on this chest X-ray? Hello.
Yes, sir, you are audible. You are
Okay.
audible.
Okay. So are there any young pediatric friends of mine who can take up this and describe it? Okay, so I will go on and describe it. So this is a chest X-ray which shows a borderline cardiomegaly. The cardiothoracic ratio is around 55 to 60%. There is significant pulmonary plethora. The right atrium is enlarged. The pulmonary artery segment is dilated. Besides this, now we are also seeing behind the right atrial border another vertical vascular, another vertical shadow. So this was a hemi-anomalous pulmonary venous return with a descending vertical vein, which we saw very well on the CT scan, but retrospectively we saw it well on the chest X-ray also.
Can you show with the cursor what you said?
I'll try. Sorry. Okay. No, I'm not able to get the cursor.
Okay. Just below the slideshow, there is also pointers where it shows pen, laser pointer, anything like that. If I get it, it's okay. It's okay.
Okay.
We have less time, so please go
Yes,
ahead,
yes.
Ronak.
Yeah.
Yes.
Okay. Okay. So any takers for this chest X-ray? Sorry. Okay, I think in the interest of time, I think I'll just go on to some of the chest X-rays, describe them, and then proceed. So this child, there is a significant biatrial dilatation seen on this chest X-ray and a significant cardiomegaly with a left ventricular sort of an apex. This child had a severe aortic regurgitation. So here we are seeing some degree of pulmonary plethora, but also there is a significant appearance of end-on vessels. So this child had an ASD, but also had significant pulmonary hypertension. And the degree of cardiomegaly that we are seeing is disproportionate to the shunt. So there was also some degree of ventricular dysfunction, which was causing the cardiomegaly. Okay, I'll just keep some important X-rays and skip. So here, this child, here it is important to note, I have kept this X-ray just to note and point out a identification of a right aortic arch on the chest X-ray. So we are seeing the tracheal shadow and we are seeing the tracheal bifurcation into the right and left main bronchus. We are seeing an indentation on the right side of the trachea, and we are seeing a vertical right descending aorta on the right paravertebral border. So this is a right aortic arch in a patient with a Tetralogy of Phallophysiology. So here also again, this is an X-ray of a patient who had a double outlet right ventricle with pulmonary stenosis. We are not seeing any sternotomy wires in the sternum. However, we are seeing some clips on the right parasternal area. So and we are seeing a boot-shaped heart. This child has had having a DORV. There is a left aortic arch, and he has undergone a right thoracotomy with right BT shunt. ECG evaluation is also important. We all know the basics of ECG, identifying the atrial wave, the P wave, the QRS axis, and the T wave. We should know the hexaxial reference system of the ECGs to identify the QRS axis and the V1 to V6 orientation in the to know the ventricular forces. Locating the QRS axis is important if we are guided by the lead 1 and lead AVF. If both of them are positive, that means the QRS axis is between 0 to 90, and that is normal. I think I'll skip these ECGs because it will be difficult. So that's all from my side. Thank you very much for this opportunity.
Thanks, Dr. Ronak. It was very extensive. We have very good collection of the photographs, and we'd like to get you back at one time once again for the further evaluations and further progress, because I know that's a very big topic as a pediatrics. Cardiac exam itself is like a very big topic. When we discuss few days back, you want me to know what exactly. So I thought to you, okay, this is the exam going students and then the practicing pediatricians are there.
Yes, so I tried to keep both some basics for the junior residents and some some aspects for the pediatricians also.
Yes. So Jay sir, are you there?
Yeah. Thank you, Ronak, for the, I think, great presentation. We heard prior on this arrhythmias in the cardiac. I think it's very difficult to cover. So I think you can talk all over night to get the glimpses of the cardiology, but time constraints. I think
Yes.
the most important thing is getting to the so that everybody got his motivation to read and refer the books, refer the clinical examination books, and there is a main motto of this. I think I think we can take the question answer later. Should we start the next session?
Yeah.
Okay.
So Dr. Swati Garekar.
Ronak, can you stop the sharing of this?
Yes.
So our next speaker is Dr. Swati Garekar. She's a senior cardiologist, pediatric cardiologist from the again Fortis Hospital, Mulund. And madam is waiting for so long because we have gone through tachycardia to bradycardia to arrhythmias and the simple exercise. So we are going ahead with the. I request her to please start sharing and should start your presentation also, madam. Welcome, please. Unmute, madam. Unmute, KG.
Please unmute first. Hello.
Hello, madam. Unmute करा देना.
हो सर हो. एक मिनिट.
Dr. Swati Garekar.
Screen sharing. The screen sharing also has to be enabled.
Ma'am, kindly try now.
Okay, thank you very much. A very good evening to all of you. Thank you very much, Dr. Samir, for inviting us over for this session, and really honored to kickstart this Maha IAP specialty subspecialty series. So after Dr. Ronak's talk on how one gets around to diagnosing CHTs, one would of course get the echocardiogram, and then it's time to talk about the timing of intervention, which is what I'm going to focus on. We will go through some common congenital heart defects all of us will encounter in practice and look at the timing of intervention. Also, we'll touch briefly on what are the long-term outcomes associated after managing these, after treating these. Remember, how we decide the timing is following the principle of primum non nocere. We do not want to harm, no harm first. Our risk of intervention, doing anything, should be much less than the risk of waiting or not intervening. In other words, the benefits of intervening must be much more than benefits of waiting. Let's jump directly to the lesion most commonly encountered by us, which is the atrial septal defect. Before that, little question to you all. Do you all understand the difference between ASD and PFO? So if not, I'll just take this slide to take you through it. Think of a PFO as the open part of the door against a frame. So that opening is the patent foramen ovale. There's a very high chance of spontaneous closure. And in adulthood, there are studies which show that cryptogenic strokes and migraines have been associated with right to left shunt across a PFO. Remember, all newborns are born with PFOs, and by the time they become 1 year old, 3 out of 4 have total closure, while 1 has still a probe patent open foramen ovale. And ASD, on the other hand, will have a hole there, hole in place. There's no flap there. It may still close if it is small. So you can say an ASD where you don't see the flap, and if it's less than 4 or 5 mm, that's essentially like a PFO. I would like to add that practically speaking, when you are imaging a neonate, the flap may be very thin. So it's almost impossible to see it, and then it's actually no use trying to differentiate. Do you want to call it a PFO? Do you want to call it an ASD? Look at the size. If it's small, you probably don't need to do anything. If you think it's more than small, then yes, a follow-up is desired. What you will also look at, of course, is if the ASD is causing any shunt large enough to cause right ventricular volume overload. This is a table I've constructed. Let's go through it row-wise. Column One talks about a small ASD, a secundum one, which is the most common kind, which is less than 4 mm. You will not get right ventricular volume overload. And if you do happen to notice it, if your echo report mentions it, then maybe it is probably more than 4 mm. And signs and symptoms are not going to be because of it, and you will probably never have to close it. So best not to label the child as having a heart defect. It has a lot of implications for the entire family. If the ASD is small, which means bigger than 4 mm or so, and there is some mild right ventricular volume overload, you still may not have any signs or symptoms in the child. And because there is, it's a hemodynamically significant lesion producing right ventricular volume overload, you would want to close it. And that would be probably, preschool age, wait 3 years of age and then do it. Remember, primum non nocere, we are waiting because there's no harm produced. The volume overload is going to disappear when you close this ASD. Let's look at row 3, which talks about a moderate or a large ASD. If the associated right ventricular volume overload is not much, then you may or may not have signs and symptoms, which might be a little dip in the growth percentile, might be some frequent respiratory tract infections. You may still choose to wait beyond or up to 3 years of age, and you may choose to give a small dose of furoped. Very clearly, the furoped will not close the hole. If some hole has to close, it's going to close on its own. And another thing, an ASD which is large enough to cause some amount of right ventricular volume overload is not going to close. Now, if with this kind of ASD, the severity of right ventricular volume overload is moderate to severe, then you're more likely to have symptoms and signs. You might want to observe 6 monthly to make sure that the child's health is not getting impacted. Remember, we place the growth of the child at a very high importance, especially the first 2 years are vital. So we do want to see a normal growth curve. And if that's getting impacted, then obviously one needs to not wait. If there is severe right ventricular volume overload, then perhaps you do not have the choice to wait and you may be forced to intervene early. VSDs. So for an isolated large VSD, it's very simple. Close them at 3 months. There's no such thing as waiting for 5 kgs, waiting for 10 kgs, waiting for this, waiting for that. No. We want this child on the road back to health as soon as possible. You're diagnosing at age, as a newborn, then wait until 3 months. You're diagnosing it at 3 months, ask the parents to get it closed and not bother about it going to close. It's not going to close. Nothing else matters where it is, how the growth of the child is, whether pneumonia history is present or not. If you have an echo report by a pediatric cardiologist talking about a large VSD, you should advise the parents to listen to the cardiologist and get it closed. Now, here's a VSD presenting a little late to us. This was an year-old baby. Terrible state of affairs, large VSD, severe pulmonary hypertension. And here she is some months after it was closed. So remarkable difference and very gratifying to see. How do we preoperatively maximize the health of the infant with a large VSD? Suppose, your patient is a newborn, is a 1 month old with a large VSD. Will you maximize milk intake, breastfeeds, plus EBM if the child is unable to suck, and supplement if required with top milk. You give, furoped with or without NVAS, perhaps start with a small dose, maximize it. If you want to, keep away from people with cough and cold, and obviously immunize completely, including Prevnar. What if you're dealing with an isolated VSD, which is tiny? So how do we tackle that? Well, the questions we ask ourselves is, first of all, is it tiny because it's being made tiny? Tiny because it's sitting next to the aortic valve and the aortic cusp is actually filling it? That's bad news. Then we don't look to see if it's tiny. We know it's large and getting small by the wrong method, and we need to close it. If there's a history of bacterial endocarditis, that's an automatic green entry into the operation theater. If there is double chamber right ventricle because of it, that again it becomes an indication for VSD closure. Remember, a tiny VSD needs follow-up. because otherwise you're not going to pick up the DCRV. The tiny VSD will have a murmur. The DCRV will also have a murmur. So we should not lose these patients to follow up. We need to make sure they follow up in the pediatric cardiac clinic once a year, etc. Now, if any of these 3 points are yes, and yet the VSD is tiny, we still need to close the VSD, as I just pointed out. The gray area is the moderate sized isolated VSD. This is also likely to need closure, but we can afford to wait and observe. We're looking at the growth percentiles. We're seeing if they're LRTIs. We're looking at the psyche of the family. How bothered are they? Are they restricting, God forbid, the child from, doing things that a child is supposed to do? Very important to never lose to follow up. What are the long-term outcomes of operated simple defects like ASDs and VSDs? As you can guess, it's very good, but we like to keep them under follow-up. The issues that can happen, for example, immediately post-operatively in the ICU, was there any temporary heart block? Because such kids, even though they go home in sinus rhythm, later on may have a heart block. Was there any residual VSD we need to worry about, and lots of other things. So we have a follow-up for all of these patients, which is stringent in the first year, and then gradually we spread it out over the years. What are the tools of surveillance we use in our OPD for our follow-up patients? There's the growth chart, very, very important, like Dr. Ronak stressed. The blood pressure measurement, pulse oximeter. We have echocardiography with appropriate size probes, very important. Otherwise, you will miss things if you don't have the right probes. Of course, the probe holder also needs to be properly trained. There's the Holter monitor, exercise stress test that we use, a 6-minute walk test, scanning procedures, and a cardiac cath. The Holter monitor is something we use where instead of a 6-second strip of ECG that you see, the pink sheet that we have, you have a 24-hour monitor. So this is what is stuck, and the patient is sent home, and telephonically you then get a record which is emailed to you, which tells you all about how the 24-hour ECG was, maximum heart rate, minimum heart rate, any SVTs, how QTCs were, gives you a lot of information, very valuable for our follow-ups. The 6-minute walk test is for kids who are very symptomatic. For example, let's say a child with severe primary pulmonary hypertension, cannot have them run on the treadmill. So we'll have them walk, and we'll see how much they walk. Then we will intervene with some therapy. Let's say we start sildenafil, tadalafil, etc. Then we have them walk again, and then we compare this year's value with the next year's value. And that's how we titrate things, figure out if they're feeling better in a kind of an objective manner. In the 6-minute walk test, they're supposed to walk without increasing their speed, not jog, just walk, and tell us how much they walk. An average child will walk around 600 to 700 meters in 6 minutes. PDA. So it's simple. If you have a PDA, the timing is similar to a VSD, except small VSDs, small PDAs, tiny PDAs, with no left ventricular volume overload, no pulmonary hypertension, we still choose to close them. Why is that? It's all about the risk-benefit ratio, because now the standard of care of closing most PDAs is via device, which is a cardiac cath procedure. You get admitted, you get it done. You can even go home the same evening. It's very safe. So any murmur that is produced by a PDA, studies have shown that it's more likely to be associated with bacterial endocarditis. The risk of endocarditis is small, but the risk of encountering a complication in closing a PDA is even smaller. We weigh the two, and turns out we can offer device closure of PDA very safely and even lower that risk of bacterial endocarditis. So we close all PDAs that produce murmurs, even though there is nothing seen in the heart otherwise. Complete AV canal, very commonly encountered in trisomy 21. It's easy. You offer repair by 3 months of age. It's a complex surgery. So occasionally, if the weight is very poor of the newborn, we may choose to wait a little bit, but we keep them under very close surveillance. Tetralogy of Phallophysiology. If you diagnose tetralogy in a neonate, you can wait till 4 or 6 months and then operate, maybe even extend up to 1 year, depending on how the baby is. Again, we're looking at the basics, the growth, the saturation, any cyanotic swells, which automatically becomes an indication to intervene. If the child is too blue, then we offer a BT shunt, and if he's not even 4 months of age. In short, if you're diagnosing a baby with tetralogy after 6 months of age, you should be directly telling them to get the surgery done soon. And this is standard of care at most large pediatric centers in India. Long-term outcomes of tetralogy are very good overall. Lifelong follow-up is required. Remember, in tetralogy, a central pathology is that the pulmonary valve is small. The surgeon enlarges the valve, so the stenosis goes away. But if you enlarge the frame of a door, the doors inside don't coapt, meet each other, so there's leakage. This leakage over time causes the ventricle to enlarge. The RV enlarges and then kind of gets dysfunctional as well. And that's when later on, maybe 10 years, 20, 25 years later, they end up needing a valve. There are also other issues like arrhythmias. There might be associative syndromes, which all impact the long-term outcomes of tetralogy. Did you know that we are now putting in pulmonary valves transcatheter wise also? So that's a humongous news for our patients. No need to undergo open heart surgery and can be done transcatheter wise. At present in India, it's costly and very limited numbers, but abroad they're using it a lot. DTGA. A DTGA with no VSD or a small VSD deserves to be operated at birth. We'll do the arterial switch. If there's a large enough VSD, which will prevent the LV from becoming lazy or regressed, then we can operate at age 1 month or so. How does a neonate who's had arterial switch surgery, how does the life look? Actually, very well. We will follow them lifelong, especially till they are growing. They finish growing till 18 and then even later. Potential issues arise like coronary ischemia, arrhythmias, and ventricular dysfunction. Remember, when we do the arterial switch surgery, an essential part is where actually the surgeon cuts along the sides of the coronary artery origin and removes that whole coronary button and translocates to another place. So imagine all those nerves, sympathetic nerves getting cut and them having to regrow to some extent. Possibilities of kinks and other issues of anastomosis. So that's where the coronary ischemia follow-up becomes important. The incidence of something going wrong is very low, but it's our job to stay on top of things. Here is a label diagram from the operation theater. So that's the right ventricle that you see and the main pulmonary artery. Oops, this isn't playing. This is after the surgery. That's the right ventricle, that's the pulmonary artery. These two patches there are actually where they've removed the buttons and sewn them to a new place. TAPVC. In a neonate, operate at the first possible time, especially if obstructed, because the only thing that can help is a visit to the operation theater. If you're diagnosing it in an older infant and it happens all the time here, even then you should try and operate at the earliest. If a baby's undergone surgery of TAPVC as a neonate, the first 1 year is tricky because they found a good 16 to 25% incidence of either anastomotic site narrowing or pulmonary venous stenosis, etc. So that 1 year, if you cross that uneventfully, everything stays good, then things are good lifetime. We do keep a surveillance for arrhythmias because of all the sutures taken in the atria. What I'd like to highlight is in our follow-up visits, actually, we detect very less number of problems, but also we get a chance to talk with families who are perhaps wrongly restricting their child because they've been told by the family that your child is a heart patient, don't let them play karate, don't let them do this, don't let them do that. Well, all we say is please let them do everything. Let them eat the butter and the paneer and everything and nutritious diet, and let them be a normal child. So I think that's another reason why follow-up is essential. Even though the child is doing very well, we need to kind of hold the hand of the family and tell them you have a healthy child with you now. Truncus. So Truncus Arteriosus, if it's duct dependent, And some cases are, then obviously you have to operate. All duct dependent lesions have to be operated ASAP. If it isn't, then you might operate at 2 to 3 months of age. Delay will mean, that pulmonary vascular obstructive disease sets in. Now there's this huge umbrella of complex CHT, various names: tricuspid atresia, HLHS, DORV of certain kinds, hypoplastic right heart, heterotaxy with all kinds of, complex heart defects, double inlet LV, univentricle. So if you look at all of these together and think about when we should intervene, then this is how I think we should proceed. First, decide if it's a duct dependent lesion. If it is, then obviously the first step of the surgery has to be done soon. Let's say it's not a duct dependent lesion, you have an infant sitting in front of you. Then what the cardiologist does is look to see if the pulmonary bed is over circulating or under circulating. If it's over circulating, you need to stop that, because ultimately for these complex subsets, we have a very well-defined management pathway. It's a palliative pathway. We do not offer any treatment. It's called the Fontan. You all must have heard of it. And that's where, when we get the systemic veins unhooked from the heart and connect them to the pulmonary arteries. So for that, you need to have the pulmonary arteries at low pressure, which is why a PA band comes in. If the baby is born with a high pressure over circulating pulmonary circuit. On the other hand, if there's something like pulmonary atresia in the complex CHT, then one will have to give something like a BT shunt. Here's a diagram of the palliative pathway broken up into the first step, which is Glenn, and the second step, which is the Fontan. So in the first step, the SVC is hooked up to the pulmonary artery. In the second step, the IVC is hooked up to that Glenn circuit by using a conduit. That's done at 4 years of age. At 4 years of age, the saturation goes to above 94%. So that's a huge surgery, but remember, you're doing it to a child who's very symptomatic and who has no chance of life without this. So it's really life saving, life altering, and talking about long-term follow-up. There's fair to good quality of life. The methodology used by the surgeons continue to improve. Our surveillance post Fontan continues to improve. And what we can offer them today for handling their complications is much more than what we could offer some 15 years ago. And there are some anatomical factors, which determine which Fontan do well, which don't. And there are other things. Even for the worst kind, which is the hypoplastic left heart syndrome, outcomes are dramatically improving. I'm actually going to end with this slide. The little kids here have undergone heart transplant with us. This is a modality we now very comfortably offer in our hospital. And most of our series had dilated cardiomyopathy. A couple had restrictive cardiomyopathy. 2 had congenital heart defects where we couldn't offer anything good for them in terms of surgery. And all these kids are doing beautifully well. So thank you. And we still have time for questions. Thank you, Dr. Samir.
Hello. Thanks for that extensive talk. Dr. Jay, are you here? Yeah, so I will talk, say that.
Sir, you can unmute. Jay, sir, you can unmute yourself.
Yes. Thank you very much. I can think a great talk on the great heart diseases. I still remember 25 years back when you diagnosed the case of any heart disease, we used to refer to the Chennai, Wilson, and Puttaparthi. But what I've seen now, if you're able to diagnose immediately, you can have a hand away cardiologist available. You can do the wonderful thing to the child, and early diagnosis and timely referral to the cardiologist is the key in all these patients. And thanks, you almost you touch all type of diseases in a very short span. And let us open forum question answer if are there any. Anybody can ask. If we see the chat box.
So Dr. Manjit Singh is there. I think he's raised his hands.
Yeah. You can unmute. All of you can unmute and.
All you can be unmute now.
And
Yes, sir. Everybody can unmute themselves.
Okay. Hi, Samir. Dr. Manjit Singh, good evening.
Hello, sir.
Can you hear me?
yeah.
Yes, sir.
First of all, a very big clap and a round of applause to the team, Dr. Samir Sadavarte, and all-time favorite Dr. Swati Garekar in the city. There is no substitute to Dr. Swati Garekar today. The way she has presented and the way she is working is something, she needs a standing ovation.
Thank you.
I think everyone should clap for this lady. Everyone. Because let me tell you very frankly, the way she has put up all the diagnosis and the carry home is the most early diagnosis. This is the carry home, as Dr. Saab, you have already said, that this such like cardiologist is available just at a hand's distance. And the way Swati has put, अरे तुम्हारे बच्चे को होल है हार्ट में, तुम ये नहीं कर सकता है, वो नहीं कर सकता है. I think we are in 2022. We are in the digital era, and I think the way Dr. Swati has said, the counseling is more important with the parents, and that is the art of a cardiologist, the pediatric cardiologist today. Hats off to Swati. Hats off to Swati. Yeah.
Thank you very
Swati,
much.
I would only, Dr. Swati, I would only like to ask the phallic tetralogy which you spoke. And in case if there is a doubt in the family or the doctors feel that this is a high risk case, what is the lifespan of this child? Now, suppose I have a child who is 11 years old, and now this is a phallic tetralogy, and you have diagnosed, means the patient has come to you and you have diagnosed, and the patient says that they have gone to 3-4 doctors and everybody has said, isko jitna jeena hai jeene do, isko operation mat karo because she may not survive. Now, this is one of those stigma which the parents always have, and it is the neighbor's university which super adds them. So how would you like to deal with such a case? I think I'm on the right track asking you this question. Thank you.
Thank you, Dr. Manjit. Your question is about a family that has been primed that the surgery advised for their child is too high risk. And I would tell them that the risk is worth taking, and the risk isn't that much as probably that was told to them. And I would share our center's experience and tell them that they have a very good chance of the child undergoing surgery and getting on with normal life. There are certain kinds of tetralogy, pulmonary atresia with MAPCAs, which are a different subset where, there are limited things we can offer, but for the, garden variety of tetralogy, we even, operate on 20-year-olds and 25-year-olds. It makes a huge difference to them. Absolutely needs to be done. So we will spend an hour counseling them, but needs to be done.
Thank you. Thank you. So well done. Thank you. Thanks, Amir, for a wonderful session. Wonderful session, really. It has really opened the eyes of all the doctors today. And I think I'm going to be the one who's going to make this viral, that we have Swati Garekar at a hand's distance, as Dr. Saab has just said. I will do that.
Similar case I am having, which is almost 13-14 years, and they are, in spite of best counseling, still they are not going for surgery because they are afraid of so much risk. Let us try. I will just send it again once more.
Please do.
I have to understand here one thing, like many of the congenital heart diseases, they are now diagnosed later on in the year, like say 50 years, 60 years, we are seeing now ASD and VSD sometimes. So what do you take on this one, Dr. Swati? Because many times they are asymptomatic for the whole life.
So I want to draw your attention to the term asymptomatic. So turns out if you ask them, they'll say, nahin, shuru se hi, we never had an interest in playing. And turns out when they tried to play, they were actually getting tired. So they kind of conditioned themselves, self-restricted, that they are not into sports, but the truth is that they couldn't. So for an ASD, a 50-year-old, where there is only a certain limited amount of pulmonary hypertension, I think it makes sense to operate. At the same time, very clearly, the advantage of undergoing closure at 50 years is different from what you would undergo had you closed it at 5 years of age. At 50 years, there's still a chance, because of chronically enlarged right atrium, that you still may have arrhythmias, because your right atrium may not bounce back to a normal size. And so Dr. Sameer, there are things like pulmonary hypertension and ventricular function, and looking at everything, we offer surgeries. For example, 1 month ago, we had a 56-year-old lady, a grandmom, undergo a sinus venosus ASD closure, and she was very happy when she came for follow-up. So, yeah.
I have a question for both of you, right? Even a smallest clinic have the pulse oximeter and everybody, right? How much it helps to diagnose a congenital heart disease, specifically cyanotic heart disease? And when it should be done? Immediately after birth, after 72 hours? We know after 72 hours there will be functional closure of this PDA, or physical closure after 3 weeks. I have seen a patient who was present as a HLH, hypertrophic left heart. After 3-4 weeks, I able to diagnose, right? I missed that patient. I managed everything about the prematurity, about the jaundice, exchange, everything was done. And that patient came in suddenly in a collapse form after 3-4 weeks of life. So how the pulse ox should be used, right? Though the pulse ox examination should be a part and parcel of neonatal examination of each neonate to be done or not, or how to do it?
Yeah, so I like to mention that universal pulse oximetry screening for all neonates is now recommended, and it is being practiced now in many newborn units and hospitals over the country. Slowly it is getting applied everywhere, and what is important is to screen in after 24 hours. The first 24 hours, the initial few hours, the pulse oximetry screening might be unreliable. So the ideal time of checking the pulse oximeter is somewhere around 18 to 24 hours or after 24 hours. So if fail test on the first go, then a repeat test is advised after around 12 to 24 hours. And if a second test also fails, then definitely a 2D echocardiogram and a complete cardiac evaluation is required. The scenario that you mentioned of a hypoplastic left heart syndrome being missed in the initial few days is very commonly seen actually. Many of the hypoplastic left heart have a sort of a compensated circulation till the ductus is open, right, and ductus closes completely, the systemic circulation suddenly collapses and the child is left in a cardiovascular collapse. Swati ma'am can add.
Yeah, I mean, you said all the right things, Dr. Ronak. If I can add one thing, which is, suppose, Dr. J, you had checked the saturation then and it was 95, and sometimes you can actually get a 95. You can be fooled. So, and then you send the child home, but this is where the concept of, follow up with a doctor, have a regular pediatrician, know what is good feeding, know, how to recognize that your baby is able to feed well, plays a very big role.
Right.
So especially more so in the first time mom who doesn't know that. So very important, for the pediatrician to have a rapport with that mother to say, listen, if you feel your child is not feeding well, you need to come back. So that's when you get the chance again to recheck if the child is tachypnic, poor pulses, poor perfusion, feeding issues, all those things I think will help you.
Right. Thank you. If any questions are there, I have a question. I will ask, but anybody?
Yeah. I have one question, like how to decide what is the optimum time, because many times it is noticed that many pediatricians say to the parents, "Iska wajan bahut kam hai, let the weight gain and then the surgery will happen, and then it will be safer side. If weight is less, your surgery will be a high risk." But what I am noticing, many times the surgery we waited, and then the child goes in the infection and died because of infection. So how to diagnose or decide what is the optimum time to do the surgeries? Of course, madam has explained about certain things, but like for the common pediatrician, what will be your advice for that?
So, sir, I think I can be very brief here. I can say that the standard of care is to operate at a time where you will stop the impact of the CHD on the child's growth, which, for example, for a large VSD means operate at 3 months. There's no two things about it. The comfort level may vary from one place to another, and obviously I cannot comment on that. There are limitations to places, and there are very good reasons for those limitations, but the standard of care, the answer to what is standard of care, remains only one. A large VSD needs surgery at 3 months. A truncus needs surgery at 1 month. A TGA needs to be operated at birth. We have done, for example, a couple weeks ago, we had an interrupted aortic arch being repaired at 1.4 kgs. Needs to be done. So,
do all murmurs need echocardiography?
So
rely on our clinical examination every time.
Dr. Ronak, are you?
Murmurs that are significant. Am I audible? Yeah.
Yes.
Yeah. So all murmurs that are significant, like grade 3 and more systolic murmurs, need an echocardiogram. A diastolic murmur of any kind will need an echocardiogram. Systolic murmur is heard, but otherwise, if everything is complete, then a complete cardiac evaluation can be postponed in a completely well-growing child who is following his growth charts and growing well, feeding well. There are absolutely no other concerns at all, and the murmur is very soft. And if we can identify an underlying condition which can explain that soft murmur, like an anemia or a thyroid, problem, a hyperdynamic circulation of any kind.
Right.
If we can put it into that clinical scenario, wait for having a complete cardiac evaluation. We should have the cardiac evaluation at the earliest.
We have Dr. Manzoor Vaniyar, who is from the Ethiopia, and he asked the question is, does the polycythemia affect the pulse oximeter readings?
So I don't have concrete data to answer your question, but let me tell you that pulse oximeter reading is even affected by the tone of your skin.
Okay.
Yeah. So one really needs to use all clinical acumen before putting, everything behind one number. Having said that, I totally support the universal screening of newborns at 24 hours of age and beyond. Polycythemia certainly may affect it. Now, more importantly, you would ask yourself, polycythemia, if it's because of a cyanotic CHT, are you really worried whether your reading is 64 or 75? Not really. I mean, if you have such a reading, you're going to act on it. You're going to get surgery done. So I would just be practical there.
Dr. Manjit want to ask something.
Yeah.
Yes.
Dr. Manjit.
Yeah, if I'm audible.
Yeah,
I'm audible?
Yes.
This question is to Dr. Swati Garekar. Dr. Swati Garekar, day before yesterday, I was in the OPD when during the health checkup, and one of the lady pregnant, almost full term, she had come to you and she was discussing. We just happened to ask her. She told one of our patient care system colleague that Dr. Swati Garekar ko dikhana hai, and I was shocked. I just turned my vision to her, and she told me mere bacche ke heart mein hole hai, and she had come to you. If I think this academy agrees that we all can diagnose this at full term or maybe 8.5 months pregnant, whatever it is, during that time, I think many of these things, if can be told to the husband and the mother, the wife would be, whatever it is, I think lots and lots of these things can be overcome. Because we have always been speaking about 76 when we joined the medical college, we were told heart attack is at the age of 70. Today the heart attack is at the age of 17 because of our disrupted dietary habits.
Yeah.
So I personally feel, the way I put it to all my health checkup patients is, you are eating which fruit you are eating, and everyone says I'm eating apples. And then I ask them, "Arey, aap to 280 rupees kilo wale apple kha rahe ho." "Haan, hum wahi late hain." And then I tell them, this is from cold storage, right? Yeah. And then my simile is that this apple is in its ICU. It's in the cold storage. So don't you think you are coming close to the ICU? No? So I would just like to ask Dr. Swati Karkar, why not we put this at antenatal care only? Let us start at Fortis, that this will also be included in it. I think this will be a beginning, a revolution for the community today, that your child with a heart illness can be diagnosed at full term. How do you opine on this?
Thank you, sir. I'll just be brief. You have raised a very important point, which is antenatal diagnosis of congenital heart defects. We can offer fetal echo, which is looking at the fetus's heart through the maternal abdomen at the same time where they get the anomaly scan done, the second trimester scan, and we can pick up most major heart defects. Today, if you are sitting in Europe or North America, most 75% of major heart defects will be diagnosed then, and then you will have, the couple will have all the time in the world to decide what they want to do and how to plan things, etc. So absolutely, needs to be done, needs to be highlighted. Radiologists, obstetrician, gynecologists, everybody needs to be aware about the indications for fetal echocardiogram and do it more often. It's a very well defined entity, the indications for. So thank you for bringing that up.
Samir, I think you can take this ball in your court and you can roll this. And I'm very sure you can do this. I'm very sure, Samir, you can do this. You can take
Dr.
this.
Manjit, can you please listen first? I will tell you one thing is like a heart disease is not very uncommon. And in India or across the world, 1 in 100, what I'm saying, please listen, 1 in 100 is affected. So like other way, 8 people out of 1,000 have congenital heart disease. So it's a huge number. As a population of India is like a 140 crore right now. If you take in that way, it's a huge number. But to remember also, not all the heart diseases required to have active interventions. Some are like in the form of having some murmurs or something like that. Yes, we need to have. So best thing will be like to have to do echo for each and every patient. Like as you mentioned, a pregnant lady must have the echo done or fetal echo done. But you have to understand that it is practically speaking at this moment for India, it is not feasible. So at least some high-risk babies, high-risk mothers who have previously has the history of having the bad obstetric history or some other problems is there. Yes, in those cases, definitely we should offer them to have the fetal echo done. Because it's a life-threatening if you come to know later, like once the baby is born and afterwards we are telling them, parents, yes, your kid has such a bad abnormal things. It is much better to diagnose this thing much earlier, maybe like say month of 4 months or 5 months, and tell the parents clearly about the guidelines and things happening. And we can save much of the babies, and even we can plan the surgeries and things later on in a way managed directions. So thanks, Dr. Manjit, for talking about this issue. And thank Dr. Swati Garekar and Dr. Ronak to do this justice so far at your places. We have one more question here, like suppose how once you diagnose the cardiac disease, many parents will have issues in the form like, do you really require to do surgery? Can we wait? And sometimes we notice that they have some affordability issues or something like, so how do you tackle such situations?
Dr. Ronak, are you going to take this one?
Yeah, Dr. Ronak also, and then Fateh Garik also.
Yeah, so we do come across these clinical scenarios where there are some logistical issues with the families, or there are some financial difficulties, and things get difficult sometimes. But the main part is that both the family and we should focus on the part, decide that the surgery or the intervention is required time, and try our maximum to. Nowadays things have changed, and a lot of avenues are there for helping these lower socioeconomic strata their heart surgeries done.
Can I speak? Ronak.
Yes, sir, please.
Most important thing, first, diagnosis of the case, that's the most important. Another importance of intervention, you should explain to the patient, refer to the cardiologist, and please use your own social status as a doctor in your field. Contact NGOs. To be on this dice, I can say I was a contact with the PA of the Chief Minister was my patient, right? I called him. पेशंट आहे असा करायचंय त्याला. ही सेड की काय नाही सर, फक्त मला एक ऍप्लिकेशन पाठवून द्या. ही सेंड द मनी. पेशंट वॉज ऑपरेटेड इमिजिएटली. म्हणजे मला म्हणायचं असं आहे की our job is to give the proper information, guide to the patient. Even corporate hospital have the social contacts and definitely they help to the patient doing that. म्हणजे मोठ्यातली मोठी सर्जरी व्यवस्थित आरामात होऊ शकते, पण तुमच्यासाठी तेवढी पेशंट मध्ये इन्व्हॉल्वमेंट पाहिजे. म्हणजे म्हणायचं असं आहे मला, आय विल टॉक इन द मराठी, की प्रिव्हियसली 1-1.5 किलोचं बेबी डिलिव्हर झाल्यानंतर हे बेबी जाणार आहे असं म्हणायचं होतं. नाव द सर्वायवल रेट इज क्वाईट हाय, as well as only even complex heart disease patient definitely can survive. That is a good life, right? HLH बद्दल मला माहित नाहीये, पण बरेच काही diseases definitely they can intervention can be done and they can have the good life for that patient also. So senior pediatrician, senior काय कोणी पण, you should use your all contacts to help to the patient, financial and as well as use your social even political contacts, right? There are people are there to help you out. इव्हन फेसबुकवर तुम्ही जर पोस्ट जरी टाकली तरी तुम्हाला 10-20 लाख रुपये गोळवतात. मी तर सांगू शकतो तुम्हाला, पण ती प्रॉपर जर असेल तर. सो आय थिंक युअर जॉब इज टू हेल्प आउट, हार्ट आउट फॉर द पेशंट अँड दॅट कॅन डेफिनेटली डन, राईट? आहेत ना तुमचे फ्रेंड? तुम्ही गारेकर मॅडमला फोन करा, रौनकला फोन करा, डायरेक्ट मॅनेजमेंटला फोन करा. या पेशंटचे माझ्या काय करता येईल? मला डेफिनेटली माहिती आहे की 3 लाखाची सर्जरी 1 लाखात होऊ शकते, 1.5 लाखात होऊ शकते. ॲज सिम्पल, आय नो दॅट, राईट? बिकॉज लॉट ऑफ पेशंट गेट ऑपरेटेड अँड दे हॅव एक्सलंट लाईफ ऑल्सो. Thank you.
Absolutely, sir. So where there's a will, there's a way. If the patient family wants it done, I'm telling you it happens.
Right.
We find a way. We have a dedicated social worker, and more so do most, pediatric cardiac centers, and their job is solely to find the way. There are enough NGOs, there are enough people who believe in us, in the good work that we do, and therefore we get help. Also, government schemes are getting better and better, and we have those as well. So I don't see why any child in this day and age should not, get the repair at the correct time. Absolutely.
Thank you. And there is question in the chat box, whether newly diagnosed mitral prolapse, what can be done? What advice should be given to the patient? Age of patient, Dr. Devidas Ghanath is senior pediatrician Panvel, did not mention the age of the patient when it was diagnosed. Please,
So, mitral valve prolapse refers to a condition where the mitral leaflets are redundant, and in systole, when they're supposed to be tightly shut, they actually bounce back into the left atrium. So that causes mitral regurgitation. In our practice, mitral valve prolapse is overdiagnosed. Personally, we don't diagnose it because diagnose it unless it meets very stringent criteria that we really see pathologic mitral valve leaflets prolapsing and producing regurgitation. More importantly, if we were to write such a thing, we always counsel the parents about how things are now, how things will be in the future. If it's just a little bit of fluttering of leaflets, there's no question of labeling anyone as having a heart disease and not letting them do certain things or be on unnecessary prophylaxis for things. I hate to say this, but I think the adult side practitioners somehow tend to overdiagnose MVPs in pediatrics. In our practice, I think we hardly make that diagnosis.
Okay. There is a question in the chat box. Can we operate a case of large VSD with SM migration? Dr. Nilesh Chaudhary has asked.
So Eisenmengerization implies that the pulmonary vascular resistance is higher than the systemic, and the VSD is actually shunting right to left. Saturation is low. You have cyanosis. You have clubbing without a doubt. Now, our focus then is to improve the quality of life. We cannot close the VSD. There's no question. And I'm talking about a diagnosed case of VSD with Eisenmenger. We can talk about how to improve quality of life by using pulmonary vasodilators at the correct time. We can talk about how eventually something like a lung transplant may help the patient years later. If you are going to tell me that, no, Dr. Swati, such a patient was operated and did well, then I would submit that perhaps they did not have VSDIs and Mengerization. They just had a large VSD with severe pulmonary hypertension. So
just talk about the lung transplant. What about the whether there are conditions where heart transplant will be done in the pediatric patient? What is the status in India?
So India is getting better and better, and it delights me to say this, that, you know, we are catching up with rest of the world. In the world, every year, there are roughly 5,000 heart transplants done, and out of them, around 500 are pediatric. In India, in the last some years, there has been a lot of interest and movement in the right direction towards pediatric heart transplant. Centers in the South are ahead in terms of, getting donors and getting more pediatric patients helped out, but we are also catching up in Mumbai and able to help our local patients. We ourselves in our series, our youngest patient was 3.5 years old when we operated. He's now 6 years old, very active on social media, in fact. And our oldest is now working. She has a job. So very encouraging. It's not something exotic anymore. It can be something that can be tackled. And we've had people from modest economic backgrounds also going for it and, doing well.
There is I think this question in the chat box. Samir, I have a question.
Questions are there. Kindly opine about the pulse oximeter at 24 and 48 hours may help to rule out cyanotic heart disease, especially in the resource limited settings.
So definitely pulse oximetry screening according to the universal newborn screening protocol. That protocol has to be followed. The first screen at around 24 hours and repeat screening 2 times after a gap of a few 18 to 24 hours if the first initial screen is failed. So this protocol, if we follow and do it and getting the reliable pulse oximetry value in a neonate is very essential. So if we do it by the book, then definitely we can rule out cyanotic congenital heart diseases in almost all cases.
Okay. Dr. Shamal Jain is asking that, sir, we had 3 cases of TAPVC not diagnosed on anomaly scan at a good center. No 2D echo facilities were available 3 months before. I was in doubt of as pulse oxy readings were some different in the 4 limbs at 24 hours. So is there any other way to confirm other than echo to diagnose such cases, because they are failed to diagnose initially? So is there something like that, particularly for TAPVC, they are undiagnosed in the anomaly scan?
Yeah, for the TAPVC bit, it's hard to diagnose it antenatally. Just like we can't diagnose smaller VSDs or ASDs, TAPVCs are also hard. But I think the real question, and Dr. Ronak can tackle that, is what does one do when there is no echo machine around and one suspects TAPVC, Dr. Ronak?
So in a small child, as we said, we should have a good reliable pulse ox saturation. If there is a desaturation, definitely there is a cyanotic congenital heart disease. If the lungs are good and the central nervous system is good, the child is breathing well. So there is a cyanotic congenital heart defect. Whether we have an echo machine or not will not matter much, because anyways the child will need a detailed cardiac evaluation and the child has to reach the nearest cardiac center at the earliest.
So the message is
with very resource limited settings, definitely we can try to look at clues on the chest X-ray, on the ECG, on the clinical exam, and come to some sort of working diagnosis. But to get a diagnosis in detail, definitely the baby has to come to a center where an echo can be done.
Okay. What about the device closure? Because many of the surgeries now can be not done and just done the device closure. So what is the advantage of using device closure?
So many congenital heart defects, especially septal defects like atrial septal defects and ductus PDA are being tackled in a transcatheter way. The advantages are avoiding a major open heart surgery on cardiopulmonary bypass. Obviously, catheterization also has its own share of concerns that have to be looked at, but overall the morbidity of the procedure is much lesser as compared to a open heart surgery, and the recovery from the procedure is also faster. So atrial septal defects, patent ductus arteriosus, and many small to moderate sized ventricular septal defects can now be comfortably taken catheter way. There are other, so that's it. So wherever the defect is feasible for a transcatheter option, definitely it help.
Dr. Jay?
I think so almost there is no questions. So thank you both of speakers for wonderful discussion and great start for the Maha IPO subspecialty chapter. And I heard both Swati madam and Ronak prior also. We have the wonderful way to give the information to our all pediatricians. Right now, I think you started from very basic. We talk about the very advanced also. So I think almost all of us are very much enlightened on this cardiology details. And we're going to, हम आपके साथ में फिर से प्रोग्राम जरूर करेंगे so that all many things can be like a cardiac arrhythmias, even this, even when you say smaller and smaller VSD or PD should be closed. So there's ever changing guidelines as well as new things are happening in the cardiology. So thank you very much for this, your time given to the Maha IP. And thank you again from all organizers. And thank you, Samir, for organizing within a very small time, right? We have very less time to given to both of them to prepare the things, but still it's gone well.
So, Dr. Jay sir, it was your vision that you did decided that we should have at least one sessions per month. That was also idea from Gangulia sir, that we should have one expert coming every month, and we will have some talk for the general pediatricians and also for the exam going student, which will be helpful for everyone. So this month we decided to go with a cardiac, and that motive was because we have the 14th February coming, Valentine and Heart. So we also have to do next month, and we decided already to do it for the wonderful session like same with a chest x-rays, and we will come back. So every Friday, second Friday, remember this, 9 to 11 p.m. in the night, we will come with a wonderful sessions like this ones. So Dr. Amol is there?
Actually 9 sessions नहीं, I have ideas of 90 episodes, तो लेकिन लोग मुझे मारेंगे, मुझे निकाल देंगे as the state convener. So
Sir, Amol sir is not there. I think Neha ma'am is there.
Yeah.
Hey, madam, you can take over.
Thank you, Jay sir. First of all, I would like to thank Dr. Ramesh Kumar sir and Dr. Vakul sir for finding time from their busy schedule and joining us today. I would like to thank our Maha IP President Dr. Hemant Gangulia sir and Secretary General Dr. Amol Pawar sir for organizing this academic specialty CME on little hearts. I would like to thank our experts, Dr. Ronak sir and Dr. Swati ma'am, for excellent brush up on pediatric cardiology. Your skill and acumen will spring hopes in the heart of unfortunate parents. I would like to thank Sameer Sadavarte sir and Jay sir for conducting the session so nicely. And I would also like to thank the pillars of our branch, all the EBs and OB member of Maha IP. Thank you for all for being so active and supportive in each activity of our branch. Last but not the least, all the attendees on Zoom as well as YouTube channel. I would like to add on, gone are the days when detecting CHD was very complex. Right. Now we have excellent craftsmen who can mend the most twisted little hearts, venturing into the intrauterine space. The magicians untangle the inlets and outlets and stitch up some holes and create some conducts. Today, the wizard has mesmerized us with their artistry. By this note, I end the session.
No conversation. I will share a small story. right? When you say negativism, diagnose केल्यानंतर पेशंटला नाही हार्ट डिसीज काय करायचं नाही. पण आय विल शेअर अ स्टोरी. ॲज अ यंग पॅडिशन आय अटेंड अ डिलिव्हरी कॉल, right, in the Kirpek Hospital, Solapur. They delivered a child of 3.7 kg weight, right? Baby doesn't cried. I intubated and I tried to resuscitation. Patient was not responding. And pediatric cardiologist not available. So adult, that sonologist, I called him and he done sonography of that heart at that time in the delivery room. And that patient was having transmission of great vessels, right? And there was no ICU in the hospital in a Solapur at that time. We transferred this patient to Bombay in a cardiac ambulance. And that patient asked at that time to me, sir, best surgery kuto hote jagat ya? So he said, in the Australia. With chartered plane, that child was transferred to the Australia and get operated within 72 hours. तर मला म्हणायचं असेल, तो पेशंट अतनूर या गावाचा होता, तिथून 44 किलोमीटरवर. तर पेशंटच्या म्हणजे त्याच्या बाळासाठी आई वडिलांचं काय म्हणजे टेक असतो. म्हणजे म्हणायचं तुम्ही हे डिसाईड नाही करायचं कधी की पेशंट हा खर्च करू शकतो का नाही. युअर जॉब इज टू गिव्ह द बेस्ट ऑप्शन. सगळे हे शान आहे की देर इज द बेस्ट ऑप्शन. पेशंट कॅन डू एनिथिंग. दे हॅव वंडरफुल ways to raise the money, but you should become wonderful doctor to refer to a right place at the right time, right? Thank you very much for again happy Valentine's every day. या प्रोग्रामचं नाव एक्चुअली रखा था मैंने, दिल है छोटा सा, लेकिन ये गंगुलिया जी ने क्या चक्कर चलाया मालूम नहीं. मेरा दिल है छोटा सा निकाल दिया उन्होंने, बोले कि प्रोग्राम का नाम नहीं हो सकता. लेकिन मैं फिर भी कहता हूँ कि वो हो सकता है. दिल है छोटा सा, लेकिन हमारे बड़े बड़े डॉक्टर्स है वो दिल छोटे को अच्छी तरह से अच्छा कर सकते हैं. तो थैंक यू वेरी मच ऑल ऑफ यू फॉर अटेंडिंग इन लार्ज. इट्स क्योंकि लोग ज्यादा अटेंड नहीं करते हैं, but I think a large number of doctors attending this session and taking I think interest in our subsession in all this academic session. Thank you.
बड़ी है आशा, और आशा जगाई है इन दोनों ने.
Yeah. So दिल है छोटा सा but बड़ी है आशा.
और आशा जगाई है इन दोनों ने. आशा जगाई इन चारों ने.
Right.
So thank you very much.
Thank you so much. Thank you everybody for this opportunity.
Thank you.
Thank you very much.